Today, I'm gonna show you how you can fix your knee pain.
Get up and get down, get up and get.
Hey guys, thanks so much for stopping by the YouTube channel. Today, we're gonna talk all about knee pain. Now, to really fix knee pain, you first need to start with a proper evaluation. And basically the idea is we need to uncover the why behind the pain. If you were to do a simple Google search, how to fix knee pain, and you find a one-size-fits-all method, you're at the wrong place. We have to uncover your individual reason for knee pain. Now, luckily enough, I have my friend Ed here today, and he's dealing with some knee pain. So I'm gonna have him sort of tell us when his pain came on, how it started, and I'm gonna take him through an evaluation. So you're gonna be able to see exactly the method I use to uncover the why behind his knee pain. And I wanna take him through a couple exercises and see if we can clean up his pain or at least start a proper rehab plan today. So Ed, tell me, when did your pain first start?
Yeah, so pain started a couple days ago. Well, actually, I should say a couple days ago, I was doing a training session that involved a lot of sprinting and bounding, so some higher plyometric activities. And then yesterday, I actually felt pretty decent. And then this morning when I woke up, I had some knee pain. It's right at the quad tendon where it inserts to the patella there. Okay. I have a history of some things on my right side, but I'm sure we'll dive into that and kind of check things out.
So there we go. So first things first, we're thinking quad tendon. A lot of people will instantly jump to saying, oh, it's tendinopathy. Let's not jump there yet. We first need to do our evaluation. Now, the majority of pains that we feel as athletes are due to problems in the way in which we are moving or inappropriate loads, meaning the amount of weight we're lifting or how many plyometrics we may be doing one day. If you're not used to plyometrics and then you just go do a ton of bounding and skipping and your body's maybe not ready for that amount of load, that can usually spark pain. So first things first, we are going to start by looking at movement. This has to be the first thing you do when addressing any type of pain. So when I have an athlete come to me with injury, especially knee, we're gonna look at his squat first. So Ed, what I want you right here is just to do a double leg squat. I want you in your normal squat stance, squat as deep as possible. Okay, very good. One more. Okay, so straight off the bat, I want you to pause at the bottom for this last one. Now right here, if you take a straight on view of this, Evan, you can see a little bit of a shift to the right side, okay? So small clues are what we're trying to uncover right now. The next thing I'm gonna have you do is a single leg squat. Now, we won't go with a full pistol, but let's do a touchdown. So I want you to jump up on the weights and we'll go left side first.
Okay.
And try a couple single leg squats. Very good. Okay. Left side looks pretty good. Same thing on your right side. Okay, not too bad. Is there any pain with that right there?
A little bit, not too bad. Squat was more painful than the
Squat was
touchdowns.
more painful.
Yeah.
Okay, so first thing we saw was obviously there was a little bit of a shift. And then actually the single leg squat off this height didn't look too bad technique-wise. But now that we know that there's a shift, there's a movement problem, what we're gonna do is sort of go from the bottom up and see if we can uncover why there was that shift in the first place. So the first thing we're gonna look at is ankle mobility. I'm gonna have Ed kneel right here and we're gonna do the simple 5-inch wall test. So if you don't have a ruler at home, a fist with an extended thumb is roughly 5 inches. So he's gonna go from the edge right here and go as far as he can. Okay, so from there, we're looking a good 2 fingers or so. Okay, now let's do the same thing on the other side. And what we're trying to uncover is there a difference side to side? Big difference. We're looking a full fist difference in your ankle mobility side to side. Does it feel like there's sort of a pinch or a block sensation?
A little bit more, yeah.
Yeah,
I don't feel that on the left side.
Okay, so uncover problem number 1, ankle mobility. Second thing, I'm gonna have you come over here and sit right there. What we're gonna look at next is tibial rotation. So he's gonna have his feet on the twos, okay? And I want you to grab your knee, and actually let's do the left one first, and rotate your foot in as far as you can. Keep the big toe base down. So don't let your foot curl up too much. Okay, and then smash your foot down. Very good, now hold it right there. Okay, do the same thing on this side. Okay, so right there you can see there's a big difference side to side as far as how angled his foot can be in. So this is looking at the amount of rotation at his tibia right here, side to side. That's another imbalance side to side. Okay, let's now look up the chain at the hips. So I'm gonna have you jump up here on the bed. Take Tommy, the skeleton, and move him out of the way. Okay, so the first thing we're gonna do up here is look at hip internal rotation side to side. So from right here, I'm just gonna have him relax. Okay, we're at about 60 degrees of hip flexion. Yeah, right there. We're looking at maybe 30 or so degrees, okay? And then we'll do the same thing on the other side. Right here. Actually not too bad side to side. So I'd say pretty similar, maybe a little bit less on this side compared to the other side. Okay, is that a hard pinch in your hip at all?
That doesn't feel bad, no.
Doesn't feel too bad. So maybe a little bit off hip internal rotation, but not a dramatic difference. Now, the next one we're gonna look at is called the Faber test. So this leg down, and we're gonna pick this hip up. Now, pelvis has to stay level, and I'm gonna have him just drop that hip down as far as he can. Now from right here, you can see how far we are away from the edge of the bed, okay? And then let's do the same thing on the other side. What we're looking at with the Faber test is the ability to extend the hip and externally rotate side to side. And again, we're not looking for whether or not he has a major restriction bilaterally, but whether or not there's a different side to side. And you can see right here, not too bad. Pretty symmetrical side to side. That's a good thing again, okay? Slide on back a little bit more. We are gonna do a single leg bridge test, okay? So we have checked out hip mobility, we have checked out ankle mobility and tibial rotation, all mobility issues. Now we're gonna look at hip coordination, basically identifying whether or not there's a different side to side in the way that his body is neurologically turning on certain muscles in the motion of hip extension. So we're assessing his motor pattern right here. So this leg's gonna be straight and his hip's gonna come up. He's gonna hold that for a couple seconds, and I wanna know, how does this feel? What muscles are turning on like crazy? Quads, hamstring, butt, or back? What's the main driver right now?
I feel glutes the most.
A lot of glutes. Okay, so that would be a passing score on this side because he feels his glutes a lot. Okay, next, with this leg up, let's do the same thing on this side. Hold up for a couple seconds. Okay, what do you feel on this side?
Same thing, glutes.
Same thing, lots of glutes. Okay, if he were feeling, you can go back down, if he were feeling maybe his quads or his hamstring cramp on this side or even his back, it would be showing that he would have an issue coordination-wise on his right side compared to his left, that we would want to be doing as far as our fixes, a number of different exercises to change the way that his body is stabilizing and producing force. So we would potentially be looking at bridges, some other corrective exercises that work more on a neurological motor recruitment pattern change. So right now it's looking like we're having a lot of mobility issues as the main cause, a lot of issues left versus right. Now, he also complained that the pain was around right here, which is the quad tendon at the very top. And it basically is the connection of all these muscles right here that come down to a common quad tendon that then turns into the patellar tendon down here. So this is where his pain's at. And a lot of people will say, well, it's gotta be tendinopathy because that's where I feel it, it's in the tendon. But here's the test that you're gonna use to determine whether or not it's truly tendinopathy. Because just because you have pain in a tendon does not mean it's tendonitis. A lot of times you'll have pain that is due to the mechanics of the knee, and we'll go over this in a little bit anatomy-wise, that will create irritation in the area of a tendon, but it's not truly tendinopathy. And the reason for that it's important to understand is because our treatment for tendinopathy will be very different for actually getting out of pain. So let's do this, jump on up. Here's the big distinction. Tendinopathy is load related. So your tendons basically act as springs. So the faster you use them, more like a spring, like a jump where you get off the ground real quickly, the more load that is placed on them. And if it is truly tendinopathy, it will be more painful the more you load it. So do your squat and rate your pain. So body weight squat, 0 to 10. 0 is no pain, 10 is the most pain you could ever imagine. Okay, back up. How much pain is that?
It's like a 4.
A 4. Now do a single leg squat. So now he has all of his body weight through one tendon, not spread with 2 legs.
Say it's like a 2. Mainly because with the squat, I was going a little bit deeper, and here I'm not. So usually it hurts more when I'm deeper into knee flexion.
Okay. And now what I want you to do are double leg jumps. So let's do 2 leg, maybe 3 or so in a row. Good. And actually, I want you to come off, hit, and back up. So let's make it more plyometric. Good. Very good. Okay. How much pain was that?
Like 1.
Like a
2.
1.
Yeah.
Okay. And then let's do some single leg ones.
Same thing. 3 in a row.
Same thing. 3 in a row. Good. Pain?
Same thing, like 1 or 2.
Like a 1 or 2. So again, we went from a double leg stance to a single limb stance to double leg plyometric to single leg plyometric, and we did not see the pain increase. So we can say that he is likely not dealing with tendinopathy. And even though he has pain in his quad tendon region, it is likely something that's coming from the kneecap, basically the patella and the weight tracking. So here's what I want to show you guys. Let's talk a little anatomy, injury anatomy 101. So we'll come over here, Evan. When we're looking at our knee, we have a couple different bones. You have your femur, your tibia, your fibula, and then you have your patella, your kneecap that tracks right there. Now, as you're going through motions like a squat, your kneecap is going to track up and down, basically like a train moving on a train track. Now, whenever you go into a squat, it's not just pure unidimensional. We also have a little bit of rotation. So as you go down into a squat, the tibia is actually internally rotating, while the femur is relatively externally rotating out to the side. And in order to maintain the train on the train track, you have to have a sufficient amount of that rotation. And what we found is that Ed had limited tibial internal rotation, which means that his train, as he's going down, is effectively being pulled off the train track just slightly. What happens is that over time, it leads to a little bit of irritation of some of the tissues around the knee and the development of pain. So even though his pain is here, the cause is not here. As a physical therapist, the main thing I try to tell people is that you need to look at other places to really find the true cause of pain. Look down at the ankle, look up at the hip, and understand their connection and how they actually change the mechanics of the knee. Because in uncovering those problems, that's where you really find your fix. So we found the imbalance down here. Let's see if we can change that and see if that automatically can change in real time the amount of pain that he was feeling. So first things first, we are going to do ankle mobility. So he had an issue with not being able to touch the wall at that 5 inches, a pretty big difference side to side. Let's do a banded joint mobilization. You want to grab the blue Luz-Algine plate right there. And let's set that up right here. Now what we're going to do is a banded joint mobilization. So I'm going to have him put his foot up on the box. Oh, other side. Okay, so from right here, he's going to get down on a knee and actually bring your foot all the way up here. Let's get a lot of tension on this. Okay, the band needs to be on the top of the foot, pulling back and down. And right here, he's going to drive his knee forward as far as he can with keeping the heel down. And he's going to hold for 3 seconds and then come back. Now, the reason for this is because the natural mechanics of the way the ankle works, you have a bone on the top of your foot called your talus bone. And as you go down into a deep squat and your knee comes forward, the tibia bone is moving this way. It's moving anterior while your talus bone is moving backwards. So with a banded joint mobilization, we are attempting to assist the natural mechanics of the ankle to allow more freedom of movement between the ankle bones, which should then give us a little bit more ankle mobility. So right here, we're driving forward, and again, make sure that knee is coming forward over the lateral couple toes. Don't have it moving in, because we want to use the exact same mechanics that we want to see whenever we're squatting. Does that feel okay? Mm-hmm. If you are dealing with a pinch or block sensation in the front side of your ankle, the band should be stiff enough with enough tension that when you drive that knee forward, you don't still feel that pinch. If when you do this motion, you're like, I still feel that block sensation, pull a little bit more tension on the band. This is about a 2 to 2.5 inch thick band, I believe, from Rogue. So this is a Rogue Monster band. I'll have a link to it in the description of this video for those of you guys who want to pick up one to do this on your own. So 15 or so, what number is that?
We're probably about there.
Probably about there. Okay, let's jump on out. Great dismount. Perfect. Let's come back over here and retest. So always test and retest. So in real time, you can see and determine whether or not you're being effective and efficient with the exercises that you're trying to do. Okay, 5 inches, driving forward, a lot better. So now we're about 3 fingers away or so. So you were a lot farther, you were about a full fist.
Yep.
So that was able to show us that that exercise is going to be a good part of your rehab plan to get out of pain. Let's go back over here. We're gonna do the banded tibial rotation exercise. So I'm gonna have you on a knee. So again, this is because he could not rotate his foot in as much as his other side, so we're missing tibial rotation. So down on the knee. We are going to put the band underneath the base of his big toe, not the tip, underneath the base. And then from right here, he's gonna grab this band. Okay, you're gonna tension the band. So pull back and then drive the knee out to the side. And you're gonna squeeze your glutes as hard as you can and hold for 5 seconds and then back. So again, it's toe jamming down to create that stable foot. He's tensioning the band every time out to the side and then driving out here. Now what we're doing is we are working neuromuscular control, basically his body's ability to use this new motion and create the needed internal rotation of the tibia. So as the tibia is coming out to the side, it's actually internally rotating and abducting. So scientific terms, it's internally rotating, it's basically tilting to the side a little bit. And this is the natural mechanics that you see in the bottom of a deep squat. While everyone has a little bit different amount of relative motion, some people are very vertical, some people have their knees really far outside, the foot has to stay stable. So the idea, some people will say, well, how far is too far for pushing your knees out to the side when you squat? It's all determined by whether or not your foot continues to stay stable. If your foot is stable, there's not really an amount that knee can come out to the side that's bad. It's still gonna be a very stable position. Okay, so we'll do 2 more of those. You feel that glute turning on?
Yep.
So if you do this correctly, again, stable foot, band on, drive the knee out to the side by squeezing your glute. You're gonna feel this really good in your lateral glute, glute medius. A little bit of the glute max produces that hip external rotation in this position. Let's jump back up here, test, retest. Okay, do that left side first, just so we have a good comparison. Very good, okay, right side. Great improvement. Big difference. Feel pretty different?
Yeah,
Good.
yeah, feels good.
So let's jump up here. And instantly, we're going to, again, retest our movement to see if the changes that we're making with the corrective exercises actually have any carryover to what we want to see in the full movement pattern. So let's do your regular squat. Good. One more. Okay, a little bit less shift in the bottom. How's it feel?
A little bit of pain, but less than before.
Less than before, so you're at
Yeah.
about a 4 or so? Where you
Yeah,
at
so we're probably like a 2.
about a 2, okay?
Yeah.
So that's good. That's a good decrease in one session. And let's jump up here and try your touchdown again. Okay, how does that feel?
That stayed pretty similar, but it wasn't that bad
Okay.
at the beginning.
So we were able to effectively decrease the pain and improve your movement quality right there.
yeah, yep.
So what that shows, again, the type of things that we're doing, it's not magic in that it's gonna take pain completely away in one session. But now that we have an understanding for the specific imbalances side to side that created the movement problem, which led to the development of pain, we now have a good rehab plan that he can start implementing to decrease his pain. And if he stays consistent with those exercises every day over the next couple weeks, we should see some pretty dramatic changes. So it's relative rest. So I probably would say let's not push through much pain with jumping, any plyometrics for the next week or so, and then able to train what you can train. So that's a big thing. We also don't need to necessarily take a dramatic step back from everything. Train what you can train. Anything that's pain-free, you know, have fun with it. Continue deadlifting, single leg deadlifts, any type of squats that are within a pain-free zone. So for some people at this time, it may be, let's not full depth squat because you had more pain the deeper you went. Maybe let's try a box squat for the next 2 weeks. That allows you to continue maintaining your athleticism, your strength, but we're not continuing to push through pain. So allow yourself to train what you can train, not only for mental clarity of still being an athlete, but it's going to allow you to not continue the pain cycle, get over this pain quickly, and get back to doing the things you want to do. Make sense?
Yep.
Cool. So guys, if you're watching this video and you're like, well, maybe I have some of those other problems that Ed did not have, what I want you to do is you can go back through all my different YouTube videos. I've got a couple different ones that are specific to problems at the hips and specific to tendinopathy. So if you did that double leg squat, the single leg jump, that entire range, and you had increasing pain, there's a very different set of exercises that would be helpful for improving tendinopathy. So go check out those other videos, and that should be a great way to sort of kickstart your healing process for knee pain. Guys, let me know if you have any questions on dealing with knee pain in the comment section below, and I'll try to get back to as many people as possible to help you guys get out of pain and get back to lifting some big weights and doing everything you want as an athlete. Until next time, guys, happy squatting.
They say that energy flows where attention goes, so I pay no mind. Why waste my time with all these negative cats scratching? So caught up in their egos, these people have lost.